Hello, and welcome to Capital Compass. We are the official podcast of the New York State Catholic Conference. I'm your host, Gillian. Today, in episode 14, I'll be talking with Dr. Thomas Carroll, a general internal and palliative care doctor and associate professor of medicine at the University of Rochester, about doctor-assisted suicide. Throughout the 2022 legislative session, we are giving you updates on what is happening in Albany. Without further ado, here is your Legislative Minute. Welcome to the Legislative Minute. I'm here with Dennis Paust, Executive Director of the New York State Catholic Conference. Today, recording the Legislative Minute, it is Monday, April 11th, 2022. Dennis, can you tell us what's been happening in Albany recently?
Thanks, Gillian. Well, we've been talking about the state budget for the last few episodes of our Legislative Minute, and the state finally passed that budget a week late on April 8th. It all got done, and we have a lot to talk about, so maybe we'll spread this over a couple of weeks. But this week, I really wanted to point out how well our schools, our Catholic schools, have done in this year's budget. And for that, we're grateful to Governor Hochul, who spearheaded some of these increases, and for the legislature, too, for going along with it. So in the budget, they have tripled the funding for non-public safety equipment from $15 to $45 million. That's for health and safety and security needs, but also, and this is critical, we can now also use those funds for capital needs for secular uses. Say if you need a new boiler or air filtration or a new roof on your school, you could apply for grants from the state now to cover that. STEM funding for our schools increased nearly 40% to $58 million. That's a huge increase, and it has really benefited our Catholic schools, mostly our Catholic high schools, where the teachers tend to teach specific subjects. If you teach religion, you're not eligible. So the elementary schools don't do as well, but the high schools have really, that's been a good funding stream for them. And finally, this is something we've been seeking. You know, we received millions and millions of dollars of federal aid for COVID relief, but a lot of that money has not been able to be allocated yet, and some of it is still sitting there. So we got language in the budget that says if that money isn't spent soon, it will revert to the governor, so she could use it as part of her emergency COVID relief funding, and she is committed to using all of those unspent funds for the non-public schools. So our schools will get another bite at the apple to get some of that COVID relief they so desperately need. So really a good budget, really a tremendous budget for our schools this year. We have more to talk about, and we'll do that next time.
And that was your Legislative Minute. Thank you so much, Dennis, and we'll be right back after a brief message. Are you interested in staying up to date with New York State legislation pertinent to the Catholic Church? Do you want your Catholic voice to be heard? Sign up for the Catholic Action Network by going to our website at nyscatholic.org/action-center or texting CAN to 50457. Again, CAN, C-A-N, to 50457. And we're back. I'm here with Dr. Thomas Carroll. He's an associate professor of medicine at the University of Rochester. He practices both general internal medicine and palliative care in the office and hospital settings. Dr. Carroll also directs the Advanced Communication Training, or ACT program, which seeks to improve patient care, supporting communication excellence among individual clinicians and clinical teams. His interests include communication training, medical education at all stages of training, and Catholic bioethics. He's also a member of the Catholic Medical Association. So welcome to the show.
Thank you so much for having me.
So I guess to dive right in here, you are here to talk about doctor-assisted suicide. So can you explain to our listeners what is doctor-assisted suicide, or as advocates call it, medical aid in dying?
Sure, yeah, absolutely. So it's something that's developed over the past number of decades, I guess. It's come more into, accepted clinical practice in many parts of the country and in the world, for that matter. So doctor-assisted suicide is where someone decides that they want their life to end, and a physician or a nurse practitioner, doctor, somebody can write a prescription where it's legal, that is a lethal prescription of medication. That person then the patient themselves decides when to ingest this medication with the intention to die.
What do you think motivates patients to seek such an extreme measure?
Yeah, it's actually that we have some pretty, I think, robust data, some information from Oregon where this has been legal the longest. I think it goes back to 1998, their data do. And as part of the process, when somebody wants to go through with this process, they have to answer some questions, check off boxes. And so they can check off as many of these boxes as they want. And there are a number of things that sort of sift to the top of the reasons why people do this. Number one, at least on these data were published in 2016. Number one is losing autonomy, right? The fear of being dependent on others. 91% of people checked off that box. Others include less able to enjoy activities that make life enjoyable. 89% of people said that. Loss of dignity, kind of whatever that means to a person, 68%. Losing control of bodily functions, about half the people. Being a burden, just a little less than half. And then interestingly, pain is only noted by 25% of people. Only 1 in 4 people actually check that box that pain is a major concern of theirs. So, a lot of the stuff that comes out around this, a lot of the sort of way to sell it, if you will, is to relieve pain and that sort of thing. And that's kind of not what people are worried about. They're worried more about being a burden and losing the sense of control in their life.
Now, I know some states you have to be terminally, or like some states and even some countries, to for it to be legal, you have to be terminally ill. So, do you know what that quote unquote definition is?
Mm-hmm. Generally speaking, yes, when that's a requirement, and this is a moving target because it keeps changing in different places. But yeah, usually terminally ill means within 6 months expected survival. So if somebody's likely to die in the next 6 months, and they get that really from, they sort of borrow, if you will, that definition from the hospice criteria usually.
How, like, I guess, there's a lot of talk about this. So with like reports, support showing that the medical community for doctor assisted suicide and everything, so few doctors actually sign up for, quote unquote, sign up
Mhm.
to write the prescriptions. So like, why is that?
Yeah, it's really amazing. In Oregon, I think it's just a small handful of doctors that sign up to actually do this. In Washington, D.C., when it became legal, I think there were zero. Like there just wasn't available. And I got to tell you, I think it's this difference between saying, well, I don't, I'm not going to try to impose my morals, let's say, people think, on somebody else, but I don't want to do it. And I think it really speaks to that sense of wrongness. I think people still have this gut feeling this is not medicine. In my opinion, I agree with that. It's not. Um, and I think that's where that sort of discordance comes from, I think.
So when we talk about, or when you think about doctor assisted suicide, one of the first things that comes to mind, as we briefly went over earlier, is the patient must be in pain or feel or in fear of pain. So from a clinical standpoint, is that really accurate? And also, like, aren't there other ways for pain to be mitigated?
Yeah, absolutely. And even the advocates of doctor assisted suicide will agree, that we can generally treat pain. I think that the trouble for patients becomes that if you will, what's the cost of treating that pain? And I don't mean dollars. I mean the stuff that comes along with that, whether it's side effects or whatever it might be. But again, it's really, really where the rubber meets the road. It's not about pain as often as many people think it is. It's more about that sense of autonomy, control over life that really is the thing I think that drives this. People don't want to be a burden is a big thing.
What are other alternatives? It's hard. It's
Hmm.
kind of, I feel,
Yeah.
it's not abortion. It's not like, you can get adopted with abortion, and other things like that. So kind of like, I guess, if somebody's thinking about it, what are the other things they can think about, I guess?
In some sense, it is similar to abortion. That person, that woman who's pregnant, thinking about abortion, still has to go through the pregnancy, still has to give birth, and still has to, have support to do that, right? It's almost impossible to do it alone. Certainly, people do and can in some sense, but doing it with support is really an important thing. And the same thing is true at the other end of life, towards the end of life. Um, we say it all the time, at least I do, to patients, that it's almost no one person can be the sole caregiver for one other person who is ill, right? You need help. You need multiple family members, maybe people from outside, whether they're professionals or otherwise. And so I think really the answer is not more morphine, let's say. That it's not a pill, right? And that's so often what we're looking for in this society of ours. And medicine responds to that, right? We're very, very good at writing prescriptions, both as a medical profession, but also a society accepting that. We're much, much more challenged when it comes to actually caring for people, right? And having enough human power to care for the person who needs the care. And I think what we find out is whether it's traditionally thought of, suicidal kind of thoughts sometimes, or an interest in this physician-assisted suicide kind of thing, or doctor-assisted suicide. A lot of that can be alleviated by a sense of support, and so truly having support around and knowing that people will care for you. That doesn't get around the trouble of not wanting to be a burden. But I think that the way to address that is to really talk about, let's get out in the open what burden means. We spend an awful lot of time, I think, as families. I see this in my patients and their families. The patient is spending a lot of time and effort thinking, I don't want to be a burden. The family's spending a lot of time and effort thinking, but we want to care for you. It's not a burden, right? And getting those two talking to each other in this particular way, I think is really valuable, to recognize that giving care is giving a gift, but also receiving care is to some extent, and in some sense, giving a gift. It's giving a gift to those people who love you and letting them take care of you, rather than just sort of, if you will, pulling the plug in this way and actively killing yourself. I think that leaves a lot of scars that are not as recognized as they probably should be.
Yeah. Now, because you work with patients, have you encountered patients asking about doctor-assisted suicide in your practice?
Yeah, yes. Probably not as much as if it were legal, I suspect. People would come asking specifically for this legal thing if it were legal in New York. Fortunately, it's not, of course. But yeah, the phrase, I guess, that gets used is, quote, requests to hasten death is kind of the way that gets talked about in the medical world. And you can imagine that being people thinking about that in multiple different ways, all the way from what we would call euthanasia, which is that rather than the patient ingesting the ultimately deadly thing, it's rather like a doctor or somebody pushing the plunger, if you will. All the way, to the other end of the spectrum, like, hey, when the time comes, can I just have a little extra? So maybe it just goes easier. And yeah, so people had that feeling like, I just want to be done. I want out. One of the things heart-wrenching things that I hear people say is, we treat our dogs better than this, right? And what they're alluding to oftentimes is, we'll put our dogs down when they're suffering, but we won't, quote, put that patient down. We won't. And I think that just ultimately that misses the difference, right, between animals and humans, right? The inherent human dignity, obviously. So yeah, people do certainly ask that question, and there's really a lot of good medical literature around how do you respond to that. And basically, what shakes out is we hear, we listen, we acknowledge, we say, you're obviously in distress. How can we help? And oftentimes, just that, how can we help, and then following through with helping as best we can, will make that fear that's driving that desire to end things dissipate. Not always, but enough that it's certainly encouraging that it does work.
So, obviously as Catholics, of course, you're part of the Catholic Medical Association. We don't believe in doctor-assisted suicide. But in a society where, marketing is everything and your choice of words kind of is a make or break, what are your thoughts on the language constantly being changed to, quote unquote, advertise this issue? For example, some have rebranded it from doctor-assisted suicide to physician-assisted suicide to medical aid and medical assistance in dying, all these different kind of wordings of the ultimate action.
Yeah, no, I think that's exactly, when you hit it exactly right, that it is about branding, it's about selling, it's about not offending people's sensibilities, right? This has been studied in terms of the acceptability of these different terms. And if you put the word suicide in there, people are less likely to agree with this thing being a good thing. Whereas if you say medical aid or medical assistance in dying, doesn't that sound nice? And the trouble is, for me, totally, if you just take the moral thing out of it just for a second and just look at what are we, in medicine, we tend to rename things to make them more specific. In this case, we're renaming them to make them less specific, right? I, as someone who would never take part in physician-assisted suicide, or however you want to call it, or euthanasia, whatever, I assist people in dying all the time, right? I help them as they die. So it sounds like that medical assistance in dying would apply to what I do, right? It's a very general term on purpose, I think. But exactly the opposite of what we generally do in medicine, right? We usually rename things to make them more specific. And the most specific thing is doctor assisted suicide, because that's what we're doing, right? And people
Yep.
disagree with me because they don't like using the term, but it really comes down to, do you agree with it morally or not? Depending on it will determine, which of these terms you like. For what it's worth, I ran into a thing in Italy that recently there was some back and forth legally in Italy about whether this kind of thing should be legal. And in Italy, the legal term for this is homicide of the consenting, which I thought really was like really in your face, right? I was like, man, if we had to use that term, I suspect we'd have some some different selling points here. But yeah, the language is really, really important, and so I think it's important that we stick to what I think is accurate and descriptive terms.
You mentioned euthanasia, and obviously we're talking about doctor assisted suicide, but can you kind of tell listeners that, differentiate maybe somebody who is in the hospital who's like brain dead, kind of the different, because I feel like sometimes people question it, and it kind of, I guess, more blurred lines in that sense.
So you're wondering, as someone approaches the end of their life, what would qualify as this thing that is not okay
Yeah.
versus more, from the Catholic standpoint, more acceptable end of life kind of interventions.
Yeah.
Yeah. So there's a principle of that's called the principle of double effect, right? Which is worth Googling that. Anybody can go and just look up the principle of double effect. Thomas Aquinas actually is one that developed, took part in developing it, and of course others. But ultimately, it comes down to intent and proportionality, right? Like how intense of an intervention, that proportional aspect to it. So if my intent is not to end this person's life, but rather to relieve their suffering, good.
Yep.
Okay, that's the first criteria. And then, and then I have to do things that are reasonable, right? So I can't give some unreasonable dose of medicine or whatever. And so oftentimes what people feel like, especially people who are very much against something like doctor assisted suicide, they'll worry that, taking this person who, as you say, brain dead, that sort of colloquial term, right? Brain dead, the person who's going to die without the ventilator, let's say, without the breathing machine,
Yep.
stopping that ventilator sometimes feels like I'm killing them. And the Catholic teaching would be, actually, we're not killing them. We're simply recognizing that there's no more we can reasonably do to help this person. And so we're going to stop these interventions. And then the thing that actually takes their life is the disease. And that's the really important distinction, is what's the thing ultimately that causes that person's death? If it is the disease, and we've simply recognized that we can't help anymore, that's the Catechism of the Catholic Church explicitly says that is okay, right? That is acceptable. If, on the other hand, it is an active an action with the intent to end someone's life, whether the doctor pushes the plunger or the patient takes the pills, that is not okay. And that's the really important distinction to make, with the understanding that this is really hard, right? When you're in the midst of this, somebody you love is dying, it never feels good. It will always be difficult. And quite honestly, we should struggle with these things, and we should question, and we should reach out for help. We should not do this alone. And even if we do the right thing, it still may not feel good. But just, we need to be aware that there are, as with really all Catholic teaching, there are these guardrails to keep us safe, if you will. But within those guardrails, there's a lot of variability about when and how and the details. And I think part of the message one part of the message I always want to get across is there's not just one right answer, right?
Yep.
I mean, there are a whole bunch of really wrong answers, but within that realm of reasonableness and morally okay answers, there can be variability one person to the next, and it can be okay. So I think it takes the pressure off us a little bit to get just exactly the right answer, but recognize that we got to get not the wrong answer, and then something that's reasonable.
Backtracking a little bit, you mentioned Oregon a few times. So for those who don't know, the state of Oregon, as literally, I was just reading an article on the Hill that was published March 29th. And so the state of Oregon now will no longer require people to be residents of the state to use its law allowing terminally ill people to die via doctor-assisted suicide, or whatever you want to call it. So, like, obviously in New York, it's not legal, but can you just tell our listeners why we should be wary of it, even though it's a different state, and like how it affects states that don't have it?
Yes. So this is a question that comes into the legal realm. So please take it with a grain of salt. I'm a physician, right? Not a lawyer. But my understanding of what's been happening is there is this residency requirement. I believe it was like you had to live for 6 months in Oregon or something to become an official state resident. And famously, Brittany Maynard, I believe was her name, moved from California, I believe it was to Oregon, the state anyway, um, to take advantage of this assisted death thing, suicide thing, and she in fact then did do it, and I believe actually died. And so the legal challenge has been that that's unconstitutional, right? That we can't restrict this based on residency status or whatever. So there is no longer a residency requirement in Oregon, and now of course the pro doctor assisted suicide groups are strongly encouraging the other states so they don't have to go through this painful legal process. Why don't you just go ahead and do it? The trouble is that I don't think there's even, not only is there not a residency requirement, I don't think there's a physical location requirement that I can tell. So it's at least in theory possible that a physician in Oregon could do telemedicine by video. The patient in New York State could ship them, do their whatever evaluation they think is required by the law, which is arguable in terms of how much there really is, and then have the medicine shipped from Oregon to the person's address in New York State, and then that person could, commit the final act, the suicide, in New York State. And so, if all of that is true, then it very much could essentially, if you will, nationalize assisted suicide in a way that we hadn't seen before.
So it's something that pro-life people should maybe watch and look into, just because it's something that, although again, it just in Oregon right now, it can really affect everybody else.
Yeah, I think it's something to be aware of. Yeah, and particularly if we're in a position, any of us is in a position to support people who are ill and might be thinking about something like this. I mean, we should always be supporting them, but this is yet one more thing to kind of be on our minds, just to be aware of. Yeah.
What would you say to a pro-life Catholic who wants to positively defend Catholic end of life teaching in like a very secular world?
Yeah, that is always a challenge because we're sort of agreeing to the terms of the conflict, if you will, right? That don't really also always support our stance. It's hard because at the end of the day, the basis, my non-theologian understanding, right? The basis of all of this is the fact that I was created as a unique creation in God's image. And I love the way the Catechism puts it. I don't have this memorized, I promise you, but I have it right in front of me. It's paragraph 2280. We're obliged to accept life gratefully and so on. Everyone's responsible for his own life before God. And then, quote, we are stewards, not owners of the life God has entrusted it to us. It is not ours to dispose of, close quote, right? That to me is just so beautiful. We are stewards, right? And so I think in the secular context, what I try to do, please, this doesn't work all the time, even maybe some of the time, I don't know. But just to point out, like, what is it exactly that I, Tom Carroll, did to deserve to be born, right? By what merit do I deserve any of this? And I think most people can, even from a secular standpoint, non-religious standpoint, perhaps, can understand that something about this is a gift, something I didn't earn this. I'm not due it. And perhaps if someone can understand something or can kind of accept something along those lines, maybe they'll start to go down the path of, and maybe I shouldn't dispose of this like it's, completely mine to do with as I please. Ultimately, though, if someone is more in the relativistic kind of, or relativism kind of mindset, it's a hard thing, because really we've got this autonomy thing that's kind of just gone wild in our culture, where whatever I want is what I should get. And the old "you do you, I'll do me," like leave me alone, live and let, I guess, die in this case, is really, it's a hard thing to counter. And so I do think we need to go back to the basics, back to the foundations of Catholic teaching and anthropology and everything else, and really help people understand where it is that we're disagreeing. Because I may not be able to convince somebody that I'm right, but if I can at least, if at the end of our conversation we can understand where we disagree, I think that is a success, because that at least allows us to have a discussion and not just yell at each other or talk past each other.
Thank you so much for coming on. We're going to have some links in the show notes that Dr. Carroll has provided if you're interested in more information. Do you have any last words for our listeners?
I really appreciate you having me on. It's an honor. I'm humbled and a little nervous here, I'll say in retrospect, but you're very kind, and I really appreciate our conversation. This is a really important topic, one that's obviously close to my heart and what I do day to day, and I hope folks will just be aware of it, um, and recognize that that we're not responsible for what other people do, but we are responsible for how we respond to the world. And if we can just offer our love and support to those around us who are suffering, that is the best in all that we can do. I think all we're asked to do. And I do think if we all did that, if society did that, I think the desire for this kind of thing would almost entirely evaporate.
Great closing there.
Well, thank you.
Thanks again.
My pleasure.
Thanks for listening to the Capital Compass podcast. If you're curious or want to learn more about Catholic end-of-life decision-making and your legal options, please visit catholicendoflife.org or contact our office for a physical pamphlet of Now and at the Hour of Our Death. Although New York State-centric, the website offers resources for those living in other states. We want to thank Dr. Carroll for coming on the show. We hope you enjoyed this episode. We'll be coming out with a new episode every other week. If you'd like to support the podcast, please share it with others, post about it on social media, or leave a rating and review. Don't forget to subscribe wherever you get your podcasts. And to catch the latest from the conference, you can follow us on Instagram and Twitter at NYS Catholic Conf and on Facebook at NYS Catholic Conference. Thanks again, and God bless.